Hello, everyone, and welcome. My name is Krista Sikowski, and I am the Clinical Implementation Lead at CMQCC. Today's webinar topic is latent labor management, and I want to let you all know that the webinar is being recorded and will be posted on the cmqcc.org site within about a week under the webinar section. Today's presenter is Beth Stephens-Hennessy, RNC CNS. She's from Sutter Medical Center, Sacramento. Beth obtained her BSN at the University of San Francisco and her clinical nurse specialist degree at the University of California, San Francisco. She's worked as a staff nurse, director, and CNS through Northern California in her 35 years of perinatal nursing. She is certified in inpatient obstetrics and electric fetal monitoring. She has a legal nurse consultant education from Hayward State University. Beth is an A1 fetal monitoring instructor and instructor trainer. She's an adjunct instructor at Samuel Merritt University and has served as a mentor for CMQCC collaborative projects. Beth was just elected the chair of the California section of A1. For the purposes of this webinar, all participants will be placed on mute throughout the presentation. If you have a question, please go to the bottom of your Zoom box where it says Q&A and type in your question. All questions will be reserved for the end of the presentation. If we run out of time for questions, we'll send responses out by email to all attendees. And with that, I'd like to turn over the presentation to Beth. Beth, are you muted?
Hello, can you hear me?
Yes.
Okay, hi everybody. Well, we're going to be talking about latent labor management. Okay, next slide. The slides aren't progressing from my side, Krista. Which they did just a minute ago. Let's see this. All right, there we go. All right, well, we're going to start in latent labor. We approach the issue of latent labor progress by identifying the start. When did it actually start? We need to use the new revised expectations for labor progress based on the current evidence, meaning we're no longer using the Friedman's curve that was based on a study in 1950s on only about 500 women. And as we know, things have changed since the 1950s. So what we're going to be discussing today is the evidence supporting the new parameters for active labor, shared decision-making, admitting in active labor, and then how continuous support, movement in labor, and water immersion are good strategies for our patients. There are 4 P's of the labor progress that we'll be discussing: permission, physical environment, people, and practices. The American College of Nurse Midwives has a very nice quality improvement bundle called Promoting Spontaneous Progress in Labor. And in that document, it has a risk and appropriate assessment for every woman who may be in labor. And you can obtain this on www.birthtools.com, which is a fabulous site. But it addresses these 4 P's that we're going to be talking about. So let's start with permission. Permission is promoting autonomy and mobility for the woman. It gives her an integrative power, which is it's a power to support the integration of her mind and body so that she feels able to respond spontaneously and expressively to her body sensations and intuitions. Movement, position changes, eating and drinking, control lighting and ambient sound, whether she's going to wear her own clothes, hospital clothes, or no clothes. And then the important one that we'll be talking about with shared decision-making is informed consent and refusal. The other P is physical environment. So instead of having just a surveillance room where the labor room has the 4 walls, hopefully a window, a lot of monitors, some posters, beeping machines, IV poles, we want to think of this room as more of a sanctum, a place where she feels like she has privacy, a sense of safety, options for comfort and mobility, choices like a rocking chair, the birthing ball, places for her to walk, and support for her partner and family to be involved. And when her family and partner feel comfortable, that helps to relax the patient also, because she doesn't have to worry about them. So including them, making it normal and part of the process. The people part of the P is guardianship versus domination. Now, I think domination is a strong term, but I like to think of it as, in medicine, we tend to have checklists. We need to get certain things done in a certain amount of time. And so, especially with the new nurses who are so focused with checking things off and getting it done, that we're sometimes more focused on the tasks instead of looking at the guardianship of what the patient needs. If we turn our focus around where we display that to the patient, because we do need to get all those tasks done, but what the patient needs to feel is that we are there for her. That develops trust and connectedness. It shows that we are attending to her and her environment, and we're there to keep a watchful eye that her needs are being met. Then the practices are physiological care versus medical management. Again, there are times we need to place medical management to have good outcomes. So we don't say we don't want to have medical management, but we need to make the focus that the patient sees is on the physiological care. Promote, protect, support that idea of we want you to have a physiological birth. Minimize routine interference. Again, we have our tasks, our checklists, but if we instruct the nurses that all of these interferences do affect the woman's physiology and can affect the way that she progresses, and try to do all of your tasks and needs at one time so that we aren't continually breaking up her routine. And then we need to develop standards for diagnosing active labor and admitting, so we aren't admitting patients who are not in active labor. So the definitions we're pretty familiar with. The labor hasn't changed. Uterine contractions resulting in cervical change, dilatation, or effacement. And the phase of latent phase hasn't changed, which is from onset of labor to the onset of active phase. But the definition of active phase has changed. It's the accelerated cervical dilatation, typically beginning at 6 centimeters. So again, typically I think is an important term because it's not only about the 6 centimeters. And it's different for every woman, so we don't want you not to look at the whole presentation and assessment of the woman and only look at her dilatation. So the evidence to support that is based on Zhang and his colleagues' study that looked at low-risk women meeting the NILIP term singleton vertex criteria. And the criteria is over on the left and how they chose the patients. They had a large group of women, more than 62,000, as opposed to the Friedman study, which was around 500 patients. The method was a repeated measure analysis to construct an average labor curve by parity, which I'll show you on the next slide. The results were that labor may take over 6 hours to progress from 4 to 5 centimeters, and over 3 hours to progress from 5 to 6 centimeters. Nulliparous and multiparous patients appear to progress at similar pace before 6 centimeters, but after 6 centimeters, the labor accelerated much faster in the multips than it did in the nullips. And here is a graph that describes that. So even your multiparous patients, until they are 6 centimeters, can take a longer time, and that's the time that they should be at home in their own environment if all assessments are conducted. I like this graph that they came up with, the partogram, and how this partogram works. On the left side is the cervical dilatation, and on the bottom are the number of hours since admission. But interestingly enough, you see that each line is for the dilatation where they arrived in a different color, but you don't have one for 6 centimeters. So actually what we did for our hospital where I work, we developed one that has just the 6 centimeter graph on it. There isn't a 2, 3, 4, or 5 because we don't want the nurses to really have to plot something until the patient's actually in active labor. And what we do is we laminate this and place it on the wall right across from the bed. We describe it to the patient when she's admitted and tell them that we're going to be plotting their progress, and we want them on the left side of the line. If their progression is on the line, we're going to be talking about alternatives or options like ambulation, hydrotherapy, and if they're over the line, we'll talk to them about options like oxytocin, amniotomy. It's really worked well because we've heard patients who will say, why is it taking so long? I'm sure you've all heard that. And then we can show them, look, no, you're progressing as expected for most women, and you're on the left side of this line, so you're doing great, keep it up. Or if they're on the line or to the right of the line, is when the physician or provider can have a discussion with them about alternatives like amniotomy or oxytocin. And we feel that they are more apt to agree to those options because they can see that they are not meeting the tracking of the labor progress. I like this partogram. This is by Swedish Hospital, and it starts at 6 centimeters. And again, if you are to the left of the first line on the left, it's normal. But in that middle area is where you're going to consider interventions. And then if you're to the right of the yellow line is when you should start discussing delivery plans. So active labor diagnosis. When I spoke at the National AWON conference about 3 or 4 years ago, and the title of my talk I thought of was 6 is the new 4. And it really was just a catchy title for the talk because it's not all about the dilatation. We do need to look at the whole picture. So Neil and his colleagues did a study about active labor diagnosis and labor dystocia, and they have the diagnosis of 3 or more painful contractions in 10 minutes and more than 75% effaced and 4 to 5 centimeters immediately preceded by more than 1 centimeter cervical change in less than 2 hours, or if they're 6 centimeters dilated. So with that information, when we have a patient that comes into your obstetrical evaluation unit, we have to talk to them about the options of being admitted or going home or further evaluation. And we all know, though, that nurse who has the best labor talk that she gives to her patients so that they feel good about going home and know when to come back. But the problem with that is it's not standardized and it's not always evidence-based. So shared decision-making is a good way to do that. Shared decision-making has been defined as a process in which decisions are shared by patients and healthcare providers, informed by the best evidence available, and weighted according to the specific characteristics and values of the patient. Shared decision-making recognizes the need to support autonomy by building good relationships, respecting both individual competence and interdependence on others. Shared decision-making is supported by evidence from 86 randomized trials showing knowledge gained by patients gives them more confidence in their decisions, more active patient involvement, and in many situations, informed patients elect for more conservative treatment options. It's an active process that results in decisions where both providers and patients are confident about the decision made. And it also addresses two of those 4 P's that we talked about, people and permission. For the people, it develops a sense of trust and connectedness and a sense of the woman that you are attending to her. You are asking her needs, her opinions, her situation. And it gives the permission for her to have that integrative power. So once she has the information, she can make an informed consent or refusal. So to perform shared decision-making, it's a 3-step process that we'll go over. There's the choice talk, the option talk, and the decision talk. So the choice talk is the planning phase. First, you step back and you summarize after you've assessed the patient and heard what their concerns are. An example of what you might say is, now that we've identified your concerns, it's time to think about what to do next. Then you would offer a choice. There's good information about how these treatments differ, and I'd like to discuss it with you. And then justify that choice once the choice is made, emphasizing the importance of respecting that individual's preferences and the role of any uncertainty that they may have. Then check the reaction. Choice of options may be kind of disconcerting, oh, I'm afraid to go home. Some patients may express that concern, and you can say something like, shall I tell you about the options of going home, what other things that we could do? And then you would either perform closure or defer closure. Some patients say to you, what would you do in my place? What have you done? What do most patients do? And you may want to defer the closure because you haven't decided yet, saying something like, I'm happy to share my views and help you get to a good decision. But before I do so, may I describe the options in more detail so that you understand what is at stake? And I like to add, and what is best for you and what you would like. Then you have the options talk. Check their knowledge. What do you know about early labor versus active labor, as an example? What do you know about eating and drinking in labor, support during labor, activity in labor? List out the options. We can send you home with your family as a support, and we'll help give them information on how to better support you. We can give you medication before you go home that will help you to relax and sleep, maybe come back in a more progressive labor. Or we can have you walk around the hospital for 2 hours and come back and recheck you. Then describe the options by pointing out the differences between the options. So if we give you medication, we're going to be sending you home soon after the medication. Or if we have you walking, you're going to be walking close by the hospital, things like that. You always want to discuss any harms or benefits. An example for the benefits are, here at our hospital, we may not allow you to eat or drink once you're in labor. Or we may have to start an IV once you're in labor. If you go home, you can move as much as you want, drink as much as you want, wear whatever you want. So show them the positives. Provide patient decision support. You may need more than one encounter. You may need to give them the information, let them think about it, walk away, come back after they've discussed it, thought about it, and then talk about it again. You want to summarize what you have provided them, almost like a teach back. So out of the 3 options that I gave you, tell me which ones you like and why. And that will help you decide if they understood the options appropriately. And then the decision talk, focus on their preferences. What, from your point of view, matters most to you is a really good question. They may say, well, I just want to do whatever I can not to have a C-section. And then you can go through the evidence-based information about how moving in early labor helps reduce your C-section rate. Elicit a preference. Be ready with a backup plan by offering more time, or be willing to guide the patient if they indicate that this is what they wish. Try to move to a decision by checking for the need to either defer, as we talked about before, or making a decision, asking them, are you ready to decide? Do you want more time? Do you have any questions? Are there more things we should discuss? And it's just amazing. They'll say, oh yes, my friend, when she had her baby last month, they let her do blah, blah, blah. So then offer a review. Reviewing decisions is a good way to arrive at that closure so that you agree and you understand what they're willing to do. So for us to be able to have that shared decision-making talk, our OB evaluation nurses have to be able to be familiar with the research and the evidence-based practice and comfortable enough to communicate it to the patient. So either that your nurses are all trained on this information that we're going to be going over in the next few slides, or you at least have some handouts or tools to give to the patient with that information on there. So the first piece of information that your OB evaluation nurses need to be familiar with is admission and active labor and the research behind it. That is, if you're admitted before active labor, it's associated with an increase in your cesarean chance. It creates potential for overdiagnosis and overtreatment. It impacts all of those 4 preventative P's that we talked about. For some patients, it costs more. But the funny thing is, at first, it may improve patient satisfaction. The patient comes in, you put them into bed in the labor room, this nice big room, you have a nurse, they're like, oh, I was right to come in, I'm here now, I might as well stay and let the nurse take care of them. But in the long run, they're not always as satisfied because they may have 2 or 3 days of labor, or they may end up with a C-section, and they may not be able to eat or drink as much as they would like to. A study by Ballot called Outcomes of Women Presenting in Active versus Latent Phase of Spontaneous Labor had over 6,000 women who were admitted in latent phase of labor. More of them, of course, were nulliparous patients, but the latent phase women also had more active phase arrest. So letting your patients know, if we admit you now, you have a higher chance of not being able to progress as well in labor and a higher chance of a cesarean birth. Neil and his colleagues performed a study called Outcomes of Nulliparous Women with Spontaneous Labor Onset Admitted to Hospitals in Pre-Active versus Active Labor. It was a prospective study of 216 women, and they were the NTSB patients that were dilated at least 1 to 5 centimeters. They were intact or spontaneous rupture of membranes for less than 6 hours, and then they performed a cervical exam on admission and 4 hours later. The results were the pre-active group didn't progress more than 0.5 centimeters in 4 hours, and the active group progressed more than 0.5 centimeters in 4 hours. And that pretty much goes along with the Zhang partogram and the progression of labor. The pre-active group was less effaced, and they also had higher BMIs. They found that the risk of cesarean birth increased by 5% for each unit increase in BMI. So with the Zhang partogram, the one caveat is if their BMI is 40 or above, you should add 2 hours to their labor progress. So with those lines, you need to move it over 2 more hours before you intervene. They also had higher temperatures after amniotomy, although there was the same, approximately the same number of amniotomies in the active and the pre-active group. They were more likely to be augmented with oxytocin, average 4 hours longer labors, and they were more likely to give birth by cesarean, but they had the same indications for cesarean as the active group. So for nurses in the OB evaluation area, the assessment piece is very important. Women who were admitted at less than 4 centimeters dilatation are approximately twice as likely to have their babies or their labors augmented with oxytocin. Of course, it's a high alert drug, which means more interventions, more monitoring, more disturbances to the patient during their labor. We recommend the use of the Bishop score when discussing the assessment to your provider. It's different to say to the provider, Mrs. Jones is here, she's having irregular contractions, she's 3 centimeters, as opposed to Mrs. Jones is here, she's having irregular contractions, she's 3 centimeters, and her Bishop score is 5. Because the provider may be more apt here into 3 to 4 centimeters to admit, but when they think of the whole Bishop score, they realize that patient's going to have a lot longer to go. And I don't know that using this tool is good for the patient, but definitely explaining to the patient, again, that it's more than the dilatation that your cervix has to do before it's ready. And that's why it takes longer. This algorithm is in the toolkit, the CMQCC spontaneous labor algorithm, and it says triage, and I prefer to say obstetrical evaluation instead of triage. But if all risk factors are assessed and they are able to be assessed and not admitted because they're low risk. You look at, is their labor spontaneous? Do they have intact membranes? Is the mother and baby stable? And are they term singleton vertex? Then you would look at their cervical dilatation. On the left side, if the cervix is less than 4 centimeters, you can give them the options of home or walking and reassessing. And I also like the idea of therapeutic rest, which we'll talk about. On the right side is if they're 4 centimeters or more, but you do have to look at every situation because, again, it's not just about the dilatation. Are they severely fatigued? Have they had multiple triage visits? A prolonged latent phase? Do they have difficulty coping? So in the toolkit, we also have a coping scale that should be utilized in the OB evaluation area, not just while they're in active labor. We do need to look at how they're coping. There are many options if they're not coping. You may assess them longer, give them the therapeutic rest, or you may have to admit them if they're not coping well. This addresses the P practices for medical management, developing a standards for diagnosing active labor and admitting. If the patient comes in and they're 3 centimeters and the nurse sends them home and they come back in 4 hours later and they're still 3 centimeters, but that nurse admits them, well, that patient's going to say, well, that first nurse wasn't very nice. But if everyone is following the same algorithm and there's consistency, then the patient understands what she needs to achieve to be admitted. The other option that we talked about was therapeutic rest. In the toolkit, it does say to include therapeutic rest in your latent labor policy. And it is a safe alternative to admission. So the role of the nurse in these OB evaluation units is very important. That nursing interaction is a critical component of the woman's ability to successfully manage latent labor in the home setting. Fear and anxiety will be reduced only if the woman feels she's supported and cared for. I think administrators need to evaluate the staffing and productivity in these areas. If we have more time spent on the patients in this OB evaluation area, getting them comfortable to go home, giving them the tools they need to go home, that saves time and bed space and nursing time on the back end using your labor wards. I know that some of your OB evaluation areas have limited beds, so you're very, very busy and you want to turn those beds over. The other thing about an OB evaluation unit is, as I said earlier, sometimes the woman is satisfied because she's in that nice big labor room with a nurse. Many hospitals are putting in, even if it's a 1 gurney in a room or 2 gurneys in a room, is where they would put patients who are in earlier labor that need to be evaluated. Of course, the patient who's coming in with, decreased fetal movement or blood dripping down their legs or fluid down their legs, you may put into a labor room. But other patients you would put in this OB evaluation unit so they don't feel like they are admitted into the labor ward already. So that's a really nice thing to set up so that the patient feels like, okay, I was here to be assessed, they assessed me, I have the information I need, I can go home now. Other possibilities are creating space and permission for activity before admission. I like this picture on the right. It's a walking map of the hospital or the hospital grounds or units. with resting stations and activities at each station. So depending on your setup in your hospital or your location, this might be a good thing to do. Other hospitals have created a labor lounge. Again, no TV with Jerry Springer, but a nice quiet room with subdued music playing, low lighting, nice comforting colors, comfortable chairs, some labor balls, where you can tell them, we want you to come back in 2 hours, you can go into our labor lounge, and then come back and we'll recheck you. And creating a labor policy or guideline. So again, everybody is consistent and the patient understands that that's what she has to achieve. This again goes back to the permission and that integrative power, giving her the permission to do all of these activities and make her informed consent or refusal. So if we do decide that she should be sent home, we first need to assess the home environment. Does she have a safe home to go to? How far away does she live? For those people with the rural hospitals, if they're 2 hours away, that might not be a good idea. Do they have the space for movement, running water, supplies? Do they have the support that they need, either family or friends, if they're lucky, a doula? And if they do, then share the interventions to help them stay positive and conserve energy. Share that with their family or friends who are going to be with them. Actually teach them, these are the types of relaxation techniques or touch techniques I want you to try with her when she's walking. Make sure she's up walking every hour, emptying her bladder. Give them instructions, and you might have some handouts that you can do that. Make sure she continues to eat or drink. Do you have a tub? That's great. We don't have a tub at our hospital. Hydrotherapy, as we'll talk about later, you can tell them it really helps with the labor pain. So getting in the tub at home would be great. So having those kinds of conversations with them. I like this tool. When we're giving them the options, we can talk to them about a lot of the options. Some people are visual, and they like to have both the auditory and the visual. This has all of the options that you may want them to review. This is on Lamaze.org, Push for Your Baby, and it's free. You can download it, and we give it out to our patients. Another piece of information that your team needs to be familiar with and comfortable with explaining to your patients is about the movement in labor. In a Listening to Mothers report, the question was asked about why women don't move in labor. The biggest reasons are they're connected to things. You put them in the bed to get their monitoring done or do their exam, and they get connected to that bed. They don't want to move because they're in pain. They're unable to support themselves due to the pain medication if we give them narcotics. Or because of the narcotics, they're told not to walk around because we don't want them to get dizzy and fall. Some women choose just to stay in one place because they don't know that moving may help with the pain. And they're groggy due to some of the pain medication. And some women just didn't remember why they didn't move. So your team needs to be able to communicate to the patient the benefits of movement in labor. There's clear and important evidence that walking in upright positions in the first stage of labor reduces the duration of labor, the risk of C-section birth, the need for an epidural. It does not seem to be associated with increased intervention or a negative effect on the mom or the baby's well-being. So it's a good thing. And again, we don't want them to be exhausted. We do need to tell them they do need to incorporate movement, whether it's changing from side to side if they're lying down, and then trying to get up and be vertical at least once or twice an hour. Give them some guidelines. So what we know about movement in labor, women who are free to move in labor, they will move. Women who are encouraged to move will move even more. Most women don't move as much once they are admitted to the hospital. One of the nurses that I work with here at Sutter Sacramento has a very good strategy. She loves to tell the women, all right, it's time for you to get up to go to the bathroom. We need to empty your bladder every hour. So once they're up in the bathroom, she sets the birthing ball right next to the bathroom door with the towel over it or her chucks, and then she busies herself straightening up the bed. So when the patient comes out of the bathroom, she looks like she's busy with the bed, and she'll say to them, why don't you sit on the ball? Or you can go over to the rocking chair, and if you want, you can even walk around the hallway while I fix your bed. And so those are the options that she gives them, and 99.9% of the time, they always do it. So evidence to support continuous labor support. So the definition is continuous labor support is about laboring women throughout the labor and birth by a trained person. And this is why CMQCC felt it was so important for us to get out a course on training labor support so that we can spread it throughout all of the nursing staff and physician staff. But if we send them home, unless they have a doula, their significant other or friends or family aren't necessarily trained. So that goes back to that obstetrical evaluation room, spending the time with their family about what types of labor support they can provide. And I think especially some of the significant others are so nervous, giving them something to do helps relieve some of their anxiety because they just don't know what to do. And the supportive care during labor may involve physical support, but also emotional support, just having someone there. Comfort measures like the ice, the heat, the hydrotherapy, and then the information and the advocacy that we give as nursing staff. What we know about continuous labor support, this is from a study from Hodnett and their colleagues, it increases spontaneous vaginal birth, decreases the length of labor, decreases intrapartum analgesia, decreases dissatisfaction by the patient, and decreases low 5-minute APGARs. So again, making sure that the patient is aware of these evidence-based studies. And the toolkit, they have a conceptual model for continuous labor support, and it just is a nice way to look at it. This puts the previous slide all into a model. Comfort from shower or tub. Again, the American College of Nurse Midwives, this toolkit they have, the birth tools, is just a fabulous site, but they do have a position statement on hydrotherapy during labor. The safety and efficacy of immersion hydrotherapy are well established for the first stage of labor. While pain relief is the only certain effect of immersion hydrotherapy in labor at this time, immersion therapy may also hasten cervical dilatation, resolve labor dystocia, and contribute to postpartum maternal satisfaction with childbirth. Again, not all hospitals have tubs, so this may be one piece of information that you would like to share with the patient to say, this is such a benefit, and you can do this at home and come back in a better labor. And then the patient education before they go home. We need to let them know it was okay for them to come in. Sometimes they're embarrassed. Oh, I came in, I shouldn't have, or this is my second time. I don't know when I should come back because I thought I should come in this time. Make it positive. Say, I'm so glad you came in. This way we're able to assess you and your baby, and we can give you information about how you're doing. And we can give you more information about things you can do at home based on your progress. Give them information about when to return to labor, but let them know that latent labor can last 20 hours. So they may think, oh, I have to come in. I've been contracting every 2 minutes for the last 2 hours. So letting them know that what they're doing is normal. It does take longer for some patients. And again, giving them strategies to do at home before they're admitted. This is from CMQCC Supporting Vaginal Birth Reducing Primary C-Section Toolkit. Give adequate anticipatory guidance during the prenatal period about early labor expectations and the safety of completing early labor at home. Well, as we know, most patients nowadays don't attend prenatal classes. Encouraging patients to attend the prenatal classes by offering low cost or no cost, offering alternatives to the sit in the room class, like online classes, so that they do have the information and have the more comfort of knowing what's going on with their bodies, that they feel like it's safe to stay home. Educate women and families on supportive care practices and comfort measures, as we said, that can be done at home. So in conclusion, supporting the progress of physiological labor is an evidence-based practice. Nurses provide essential components of assisting women to make care decisions, provide information, facilitate physical activities that support the progress of their labor. Thank you.
Okay, Beth, are you ready for some questions?
I am.
So the first question we have is, why do we use the 4 centimeter cutoff for decision making in the OB assessment algorithm rather than 6 centimeters?
Because again, the 6 centimeters is only looking at dilatation. You really need to look at all of the other aspects as that one slide displayed. So 4 centimeters with the contraction, the painful contractions, does show that they are progressing to active labor.
The next question is, do you have a preferred outpatient medication regimen for those needing help coping but desire to go home during latent labor?
You know, since I don't order those, I think it's very physician specific. And what we used to use in the older days are medications that we don't use very often now, but I've seen just differences. So I would say no, I don't have a preference, and it really is up to the physician. But what we want to encourage is that it's still safe to do that, and it is recommended to do that, especially those patients who are very anxious or not coping. Sorry.
Do you have any good resources to share with significant others for labor support techniques? They really appreciate having something to refer to.
Well, I do like that keep calm and labor on. And I know many hospitals have developed their own, where they have pictures of the different positions that patients should try and different alternatives. So you can, the one I use and we use here is the Lamaze Keep Calm and Labor On, but I've seen some really good homegrown ones too.
So I think you cut out, it's the Moz International Keep Calm and Labor On, correct?
Correct, correct. But I have seen other hospitals who develop really nice ones for their own, where they can put their own hospital name on it, and it's been approved by their hospital obstetricians and providers.
And then I think these two questions are pretty similar, but I'll read them both. How can we fulfill fetal monitoring requirements during latent labor, as well as allowing ambulation and movement? And regarding monitoring in a normal labor situation, is there anything in writing that spells out how to monitor intermittently? Some people will monitor 20 minutes every hour, which seems excessive to me, but there's nothing in writing that's decisive.
A1 just came out, I want to say last year, with standards for monitoring for latent labor. There's also, especially with the ACNM website, auscultation or intermittent monitoring. So you don't have to monitor 20 minutes every hour. You're right, there is nothing that says that you should do that. Auscultation has just as good outcomes as continuous fetal monitoring. So training your nurses to perform auscultation, because it is a competency to do that, or even the intermittent monitoring with the monitor from the Doppler from the monitor. Either one of those is good, but you don't have to do it continuously. It's usually 30 to 60 seconds before a contraction, during a contraction, and then 30 to 60 seconds after the contraction. And then it's every 30 minutes in latent labor that's all that you have to do, plus checking the uterine contractions. So there is a position statement from A1 that you can go on their website for their fetal monitoring, or go to the ACNM website.
Can you repeat the statement regarding BMI greater than 40 and adding an additional 2 hours for dilation?
Yes, research has shown that obese women take longer in labor, and we're talking about women with a BMI of 40 or above, and they also require more oxytocin. So the research has shown that on the average, women with a BMI of 40 or above take 2 hours longer than the average weight woman does. So you do need to give them extra time.
Let's see, I think just another question came in. This is a little bit unrelated, but we'll put it out there. Beth, do you have questions, suggestions to working with MDs who are still setting elective inductions before 40 weeks?
Hard stop. That's the only thing that worked at 2 different facilities where we placed the March of Dimes 39-week initiative, was if they wanted to schedule the patient, they could not be scheduled until they had the approval and review of that case by either your chief of OB or your perinatologist. So there had to be some type of hard stop. Just educating the providers on the benefits and what they should do didn't seem to be enough. And we've had some times where the reason was because their husband was being deployed to Afghanistan the next week. And so the perinatologist did say, okay, I understand, we will do that, although they need to understand the risks and benefits, and that should be clearly documented. So that's been my experience, is that just education for the providers is not enough. There has to be a hard stop and a second review is my recommendation.
And I'm not sure I understand this question, but maybe you will, so I'll ask it. Can you share this latent labor in regard to the EMTALA false labor information?
Oh, I was just talking about EMTALA this morning. Yes, because I cannot tell you anywhere that I've ever heard of that someone has received an EMTALA violation for sending a patient home in latent labor if they've had a thorough assessment, and in your standardized procedure, you outline under what conditions you can send the patient home. So it has to be clearly defined. and you're calling your obstetrician anyway to let them know before you send them home. So as long as you have your standardized procedure with identification of what condition you can send them home, and latent labor should be one of them. And it would say after like a category 1 tracing, you know, no rupture of membranes or whatever you decide is your institution, because there are some institutions that send patients home with ruptured membranes. That's a whole other talk. But I cannot tell you that I've ever heard of a violation for sending somebody home in latent labor after a thorough evaluation.
Question just came in. Wonderful talk. This seems very pertinent to spontaneously laboring NTSV patients. However, 30 to 40% of NTSV require an induction of labor, indicated non-elective. Do you have any similar tips on labor support for our patients that require an induction of labor?
The labor support courses that we offer through CMQCC, or even I've gone to several that were not by CMQCC, you know, are so important for the nurses to attend, not just initially, but ongoing, so they feel comfortable with labor support. And if they're elective, another option may be looking at outpatient misoprostol or Foley bulb induction. I know one of the CMQCC talks was by Dr. David LeGroux, and we've implemented that here, where we have patients who have a lower Bishop score, but they're gestational diabetic or chronic hypertensive, and we don't want them to be that 3-day induction that ends up in a C-section. So trying not to admit them with a low Bishop score, maybe doing the outpatient, or if you have to, incorporating that, the latent labor support, diet and fluids and movement, incorporating all of that, even if it's a 2 or 3-day induction.
Do you have the website or the reference to the BMI of 40 or greater information?
I do, but I don't have it right here in front of me, so I can get that to you and we can put it on the website.
Absolutely. And then someone's just letting us know that Lamaze International offers an evidence-based labor support workshop as well.
Correct. Yeah. So I've been to others, and there's, you know, any really good, well-known labor support workshop should be mandatory for labor nurses.
So a couple of things. We did touch on David LeGroux and Elliot Main's induction webinar, so I want everyone to know that that recorded webinar is available on the cmqcc.org website underneath webinars, so that you can review that as well as the slides. This recorded presentation and the slides, which many of you have asked about, will be on the cmqcc.org website within the next week, again under webinars. Additionally,
can I interrupt? Also, Holly's webinar on auscultation and intermittent monitoring, they should review.
Yes, and that's all in the same section under webinars. For all of the members of CMQCC, so all hospitals that are members and all staff that work at those hospitals also have access to a sharing platform actually called Share, S-H-A-R-E, in which you can get sample policies for some of these things, as well as some posters and handouts that other hospitals have developed for patients in latent labor, so that you can use that to develop your own. And unfortunately, that resource is only available to members at this time. But the webinar and the slides will be openly available to everyone attending on the cmqcc.org website. And Beth, does Sacramento have a policy on outpatient cervical ripening?
We do. We have policies that we would be willing to share, and we have patient discharge forms and patient information forms that the doctors give them in the office if they schedule it from the office. So I'd be willing to share those too.
Okay, so if you send those to me along with the BMI information, I'll send that out to all attendees.
Great.
Okay, thank you everyone for attending, and thank you, Beth, so much for presenting today.
All right, thank you.
Bye-bye.
Bye.